Thank you for joining us. Welcome to LifeLight Network's Thought Leadership Series. This series is designed to share data, information, best practices, and experiences by the LifeLight Network team with the hope of contributing to a larger body of knowledge. Today, we'd like to share with you LifeLight Network's multidisciplinary work in our educational session titled Designing an Escape Fire, Initial Response to a Healthcare Crisis. The hope or goal with the information is that all of us can better prepare for the next pandemic, outbreak, or health crisis. Please note that we are recording today's session. If you have any comments or questions, please place them in the chat. I'm Greg Plenner, the Director of Marketing at LifeLight Network. Today's multidisciplinary panel of LifeLight Network team members is Susan Gidding, Director of Quality Management, Lolita Ham, the Director of Business Intelligence, Veronica Mitchell-Jones, our Customer Service Manager and Flight Paramedic. These are the 5 key objectives of today's presentations. The team will discuss the importance of using a multi-departmental approach to building capacity, pivoting from a reactive to a planning model, working in complex and adaptive systems, the benefits of using data to drive decisions, and we'll talk about why it's important to have an appreciation for exponential growth. If I could, please allow me a moment to share with you information about LifeLight Network. LifeLight Network is the nation's largest not-for-profit air medical transport provider. We're based in the Pacific Northwest and Intermountain West, and we serve close to 15 million community members throughout Oregon, Washington, Idaho, and Montana. Our organization, as it continues to grow, has more than 750 team members, 25 rotor-wing bases, 9 fixed-wing bases, 2 neonatal and pediatric bases, and we operate 30 ground ambulances. LifeLight Network is part of a 4-hospital owner consortium: Providence Health and Services, Legacy Health, Oregon Health and Science University, and St. Alphonsus Regional Medical Center. The combined strengths of these world-class health institutions ensures that the quality of our program remains as safe and strong today as when it started in 1978. We'll begin our discussion today by looking at exponential growth. And for that, I'll turn it over to Susan Gidding, our Director of Quality Management. Susan?
I originally presented this information at the Northwest Patient Safety Conference last fall. However, we felt it was important to share this information with an even broader audience. For today's presentation and webinar, I've added 2 subject matter experts, Lolita and Veronica. Thank you. So this is LifeLight Network's story, and we hope you enjoy. So I'll begin talking today about exponential growth because it's really, really important. So like many people, I sometimes struggled with understanding or appreciating exponential growth and sometimes even risk, especially when the risk was in a country far away with a minimal number of sick and infected people, and when public health officials downplayed events and potential for spread of a deadly disease. Sound familiar? So even though I remember how fast the H1N1 flu spread throughout the country and our world, initially I may have underestimated the risk of the novel coronavirus. Michael Lewis, the author of the book, The Premonition, A Pandemic Story, explains exponential growth using the Mann Gulch fire as a metaphor. I don't know if any of you have read this book. I highly recommend it. You can see it in the references at the end of the presentation. Donald Berwick, MD, he's the founder of the Institute for Healthcare Improvement, has spoken many times on this topic, and he's the author of Escape Fire, Lessons Learned for the Future of Healthcare. I also highly recommend that read. Now, let's discuss the Mann Gulch fire. This fire occurred in Montana in 1949, where 13 of 16 smoke jumpers fighting the fire were tragically killed. On October 5th, 1949, at 4:10 p.m., the times are important, so I'll mention them several times. 4:10 p.m., the Mann Gulch smoke jumpers landed and were ready to start fighting the fire. Most of these men were used to fighting slower moving forest fires and not quickly moving grass fires. They had their plan and escape route, the river. But as they neared the river, they saw the fire had jumped the river and was coming straight toward them. They lost their escape route. There was a wall of flames 30 feet high heading toward them at 1.2 miles an hour. It's now 5:45. Only 10 minutes later, at 5:55, the firefighters turned and attempted to outrun the fire. It was now heading toward them at 7 miles per hour. The ridge they were running up was a 76% slope. That's almost straight up. There was a 30-mile-an-hour wind fanning the flames. running uphill, carrying very heavy gear, a fast-moving fire at their backs. It seemed nearly impossible to outrun the fire. At 5:56, the men were overcome by flames. One of the Mann Gulch firefighters, his name was Wagner Dodge. He had a novel idea. His idea was to set an escape fire. With the fire just minutes away, he lit a second fire up the hill. He burned the grass in front of him and walked into it. He threw himself down on the hot coals and survived. Unfortunately, he was the only firefighter that used this novel approach, and he was only one of 3 men to survive. His escape fire was both an ingenious solution and a leap of faith. It turns out fire is a good metaphor to convey how hard it is for people to wake up to a threat that is growing exponentially. Here's a quote from the book, The Premonition, A Pandemic Story. "You cannot wait for the smoke to clear. Once you see things clearly, it is already too late. And just like a fire, you cannot outrun a pandemic. By the time you start to run, it is already upon you. Identify what's important and drop everything that's not. Figure out the equivalent of an escape fire. We must all learn to pivot quickly." So exponential growth, I know we talk about this all the time now. The beginning of the pandemic, I think many of us were like, oh, wait, what's that? If you want to learn more about this, or if you want to teach somebody about exponential growth, this is a really good question to ask. What would you rather have? $1 million, I'm going to hand you $1 million right now, or a penny that doubles every day for 1 month? I want you to go ahead and put your thoughts into the chat. I'm going to go ahead and proceed because we are going to circle back around to this question at the end of the presentation. Go ahead and put your thoughts down. You want $1 million right now? You want a penny that doubles every day for a month? A little history lesson here. Here you can see a cute little girl wearing a face mask, a cleaning crew wearing hazmat gear, a patient in isolation, patients receiving shots at a mass vaccination site, and multiple newspaper articles. Looking at this, what year do you think this is? Once again, quickly put a response into the chat, and Veronica will monitor the chats and she will report what you guys say. What year is this?
2020, 2000.
Okay.
And there's a few people that won $1 million. I'm just going to throw it out there. We're going to circle back on that one.
I want $1 million.
I know.
Okay, I'll tell you about this slide. So a young girl wears a face mask to protect herself from the swine flu at the Los Angeles International Airport on May 1st, 2009. These Ghostbuster looking people were actually members of a cleaning brigade disinfecting a subway station on May 2nd, 2009 in Mexico City. Below are several newspaper clippings. It says, illness spike, sudden turn for the worse, flu shot rush. Need a shot? Get in line. Supply chain issues. High school closed after 40% of students call in sick. Even though I was highly involved with the H1N1 response, it was still really difficult to appreciate exponential growth and personal risk during the early stages of the COVID-19 pandemic. At the time of the H1N1 pandemic, I was actually working as a clinical supervisor at a large healthcare facility specializing in pediatrics. One of my duties during the pandemic was to report to the state our daily census, how many flu patients we had, ICU beds, specifically pediatric ICU bed availability, PPE supplies, number of available ventilators, and staff. Does this sound familiar? Did any of you have to do this? I bet it kind of sounded like your recent past. Sadly, we ran out of PPE, we ran out of beds, medical experience, and we experienced significant staffing challenges. I often had to explain to the nurses that the masks and the PPE they had in the morning, that was it. There was nothing else coming. That was going to be their mask and PPE for the rest of the day. We set up tents in the emergency room because our ER was overwhelmed with flu patients. We trained our ER nurses how to set up and operate ventilators. On our worst day, we had to decide which pediatric patient was to get our one remaining bed and ventilator. There were 5 children who needed this. They were critically ill. And at the time, I remember thinking, oh my gosh, this should never happen again. I know we will be prepared for the next pandemic. We have to be, because this was horrible. And yet, we were not better prepared. So it's timeline of events, kind of circle back around a little bit. It's January 2020. A scientist in China confirms that a mysterious new pneumonia-like illness identified in Wuhan, China, in December of 2019 can be transmitted human to human. On January 11th, China reported the first case of COVID-19. On January 21st, the first case in the US was reported. On January 22nd, Wuhan, China goes on lockdown. By February 2020, 1,500 people had died in China. The first death of COVID-19 recorded in the US occurred in Seattle on February 28th, 2020. The virus spreading without symptoms. Clearly, we were behind the curve in terms of containment. On March 11th, not until March 11th, 2020, the World Health Organization declared COVID-19, the disease caused by SARS-CoV-2, a pandemic. By April 2nd, the pandemic had killed and sickened more than 1 million people in 171 countries across 6 continents, killing more than 100,000. May 17th, 5 million were infected. June 11th, there were 500,000 deaths and over 10 million confirmed cases. That was exponential growth. So let's compare the Mann Gulch fire to our COVID-19 timeline and response. According to Dr. Carter Metcher, as he was a senior advisor for the Public Health Veterans Affairs, he stated, it's February 22nd, 2020. We are at the equivalent of about 5:44 at the Mann Gulch fire. When we reach 5:45, there will be chaos and will be panic to get anything in place. February 27th, 2020. We already have significant outbreak. We are now well past the equivalent of the 5:55 moment at Mann Gulch. You cannot outrun it. March 12th, 2020. It's 5:56 at Mann Gulch. We realize we are well behind the curve and there is no outrunning this pandemic. We are going to need an escape fire. So I mentioned chaos. I mentioned chaos and panic. Let's just talk for a minute about chaos and panic. According to Dave Snowden's framework for decision-making, the chaotic is one of 4 domains. This environment lacks any order. No patterns emerge. Snowden argues, I quote, chaos represents the consequences of massive change, like a pandemic, right? This is the domain that requires crisis management. In this realm, the most important thing to do is act. There is no point wasting time analyzing or categorizing information. There are no patterns. In chaos, we act, we sense, we respond. Is this what Wagner Dodge did? Is this what we did at Lifeline Network throughout the world? Okay, an emerging threat. This is a picture of an emergency medical facility built in China, which has 2 floors and can hold up to 1,400 beds. This facility was built to relieve hospitals that were already swamped from the epicenter of the virus, which has a population of 11 million. A second medical facility was built about 25 miles away and has 1,600 beds. The facility in this picture was panic-built in an effort to contain the coronavirus, and at the time, only an epidemic. The build was completed on February 2nd, 2020. Question, here's another question for you guys. If you saw this picture on the news back in January 2020, go back, what were you thinking? First of all, did you see it? Do you remember seeing it? And if you did, what were you thinking?
I would have thought it was a mall. I'm not going to lie. I would have thought it was a mall or some sort of like casino or something of that nature.
Greg, do you remember seeing this?
I don't. Outside of before your presentation, when we discussed it previously, I don't remember seeing this. But conceptually, if I would have seen this in February, like before everything happened, lockdown in March, this would have scared the hell out of me, quite honestly. If they have to take it this seriously and build complexes to contain it, I knew it'd be bad, but this is scary.
Lita, comments?
I do remember seeing this picture in a lot of headlines and about this new pneumonia in China. And I did not think it was, I thought that it was serious, but not that it would be a serious threat here. Because my connection, like the connection that I made was to the original SARS and MERS as well. And they were very, very serious, but they were contained, at least outside of my sort of world at the time. And I just assumed that this would have the same outcome.
Right. Veronica?
But I think
Okay.
it's interesting. I think that, this brings up a really great question about in January of 2020, when we heard, oh, COVID, it's this thing, like people are sick, it's, and I think that it got minimalized because, we really didn't see a lot from H1N1. I mean, yes, there was a lot to it. The general population didn't necessarily see it. And so, I mean, I remember standing on the street corner in California and there's a group of people and we're like, oh, did you hear about like COVID? It's like this thing. And that was when the first case was in the United States that same day. We grew so quickly up and after that, but I think it was hard for people to conceptualize because they just weren't faced with the same type of response or illnesses that you could see, the family members, there was less of that. So, here is, I didn't see this. However, I would have definitely given more attention to what was going on. And I would be asking, what do they know or understand that we don't?
I love that. I do remember seeing this, and I thought at the time, just because I did remember the H1N1, I thought the problem was much worse than we were being told. And I thought that they were actually making a case for responding to exponential growth. And I remember thinking, oh my gosh, we're so far behind the curve. And true story, I wrote a list of supplies and I sent my husband to the store and I'm like, Steve, get this stuff. And no, we didn't buy toilet paper. But I do remember that. Okay, so now we're going to get to more of the life flight response. And here's the why. I like this quote. It says, as healthcare leaders, it is essential we ponder what the pandemic can teach us about how we can think differently about the future. And I believe that we all think differently about our future now. What we needed? Well, we needed a lot. We needed PPE. We needed to have an uninterrupted transport service. We needed decontamination procedures and supplies. We needed research and education. We needed to make supply equal demand, tracking and reporting of COVID-19 cases, and we needed a COVID-19 dashboard. So several days after we were sent home from the office, I got sent home in mid-March of 2020, I was asked to help with some system improvements related to COVID-19, including obtaining PPE, tracking and distributing PPE and decontamination material for equipment and aircraft. My initial efforts would work closely with clinical leadership and our supply chain manager, but what I soon realized is that our supplies were getting low and the usual supply chains were drying up and our current system was not robust enough to keep up. Change was coming and it was coming really fast. It was really scary and we needed help. So we gathered a team of experts. Oh, and by the way, we needed to improve multiple systems. We needed to design and build data collection tools, design a COVID-19 tracker and dashboard, pivot to a predictive model using internal data, external state, federal, and private dashboards. And we needed all this done in less than 2 weeks. Actually, we needed it sooner than that because we were, as you know, already behind the curve. So the hospitals we service had surge plans during this early stage of the pandemic. They still do. Part of their plan was to move patients out of the hospital, both for acuity level and bed control. So Lifeline Network was part of their surge plan. Therefore, we could not interrupt our service. How did we do this? Hierarchies needed to be dismantled. Micromanagement and bureaucracies needed to be reduced. Staff had to step out of their usual roles and respond to system needs, experimentation and rallying across the system to be part of the solution, communication and transparency and sharing of information, ideas, and solution across all levels of our organization, along with innovative approaches to complex problems that occurred. We found that pivoting from our traditional quality management framework to a planning model during the early stages of the pandemic proved to be extremely beneficial and necessary. So using profound system knowledge to build on existing organizational capacity and infrastructure, engaging multi-department human resources and advanced analytic tools. In other words, we changed quickly. The following is a quote from Joe Mechanic. He's an IHI, Institute for Healthcare Improvement faculty. And here's a quote from him. I like this quote. He said, "Every healthcare leader I talk to right now has been inspired and motivated by the freedoms provided and afforded by their local, state, and federal authorities. It has allowed creativity and innovation to flourish. One of the few positive aspects of this pandemic is to see how much transformational change is possible. As we learn the lessons of COVID-19, it is important to consider how this period has led to unprecedented creativity. I agree. With the clear and present danger upon us gone, at least for a period, with the complex roadmaps, the 200 project inventories, I wasn't sad to see those go. Suddenly we all had one focus: beat back the virus. I do remember how that feels, and I wonder if you guys remember how that felt too. I felt like we really did have one focus at that period of time.
Absolutely. Yep, it was all hands on deck, and this is what we need to do to maintain and be able to be part of the solution.
I thought it was really inspiring to me at the time. I remember reading all of these tweets on my Twitter feed of all these scientists that were coming together and sharing ideas and things that normally would be contained within an institution as intellectual property. People were sharing and people were putting their information out openly. And it made such a big difference in the speed at which things were developed. And I just remember thinking at the beginning, like, our systems are failing us, but the scientists are going to save us. It was complicated and confusing, but it was really hopeful to see people working together in a way that I had never seen before.
If any of our audience has any comments they'd like to put in the chat, feel free. I do remember just feeling so proud of our entire team then. It was amazing. It was exhausting. It was just amazing. We built this great team. So who was this team? I really relied on them. So it was a collaboration of business intelligence, clinical, customer service, quality management, safety, and supply chain departments. And we worked to redesign our PPE supply chain distribution process, ground vehicle and aircraft decontamination process, tracking and reporting of COVID-19 positives and PUI transport, real and potential crew exposures and surveillance. This was an awesome team. We never heard anybody say no, not one time, or this can't be done, or that's impossible. We only heard, yes, we can do that. I can do that. I heard, give me an hour, give me a day, I'll get back to you. But we systematically worked every problem as they came our way, and we would test our ideas and action items. And if they worked, great, we kept them. And if they didn't, we aborted. We just dumped them quickly. So that actually sounds like our PDSA model or cycle, right? So with unprecedented creativity, breaking down complex systems, and minimizing hierarchies, these are all necessary agents during a pandemic response. Supply chain. Although we had a good process, our supply chain definitely needed some improvement in terms of tracking, distributing, and reporting. First, we performed a needs assessment, and we quickly made Aurora company headquarters our distribution center for PPE supplies. All supplies obtained were to be sent to company headquarters unless the materials manager determined there was an immediate need at an outlying base. In this case, supplies might bypass our distribution hub and then go directly to a base in need. In the past, if bases were low on supplies, one base might send supplies to a neighboring base without first being sent to headquarters. So our materials manager then worked with our supply chain database vendor and requested a PPE supply report be built differently and sent to him in a more user-friendly and efficient manner. And I was so grateful when he did that. I'm sure Lita was too. These reports were then sent to key stakeholders at Lifelight Network daily. So all the bases were required to count and enter the number of PPE and cleaning agents into the supply database daily. But more importantly, our crews were provided specific instructions on how to count each item. We absolutely needed standardization to obtain accurate accounting. This eliminated variation. The data was later pushed to our new COVID-19 dashboard and used as a part of our burn rate calculator and predictive modeling. And Lita will explain a little bit more about that soon. Ultimately, we were able to use our dashboard and predictive modeling, along with state and county reporting of COVID-19 cases and hospitalizations, to move PPE supplies to the next local hotspot. Moving supplies ahead of demand is possible with this model. We'll discuss this in more detail when we review the dashboard slides. I do have a question for Veronica about our supply chain challenges. And I know that our customer service managers were wonderful. And if it wasn't for them, I mean, they were really the true heroes here. And I know you've got some really great stories.
It was a challenge. It was a big challenge, mostly because everybody was looking for PPE. It wasn't like, well, we just had an isolated incident or we just had an isolated outbreak. This was nationwide. And so everybody became very panicked, because they realized that their supply chains at the burn rate necessary was going to last them days, if not only a day. We had providers that were literally having to use PPE on every call in EMS and hospital, because we didn't know back then. We didn't know how this was being, transmitted. And so it was very challenging in the beginning. And we had to become creative in how and who and where we were asking to get PPE. And there's probably some crazy stories that everybody can appreciate, but we were willing to ask anybody who had quality PPE. We reached out to nursing schools. We reached out to veterinarian offices. We reached out to anywhere that we thought that we wouldn't be taking it from another resource that was immediately needing it. So, schools were being shut down at that point in time. That gave us access to go there. We were trying everything, and there was a lot of late nights and lots of phone calls. And then it was sometimes necessary to essentially barter PPE. Hey, I've got gowns and you've got masks. Do you want to make some trades here? And that kind of let us get to the point where the state was able to come in and we were starting to track and get everything on board. And then, state shipments came out kind of slowly too. And so it was a lot of, okay, what can we do to make this go on? And it was also being practical in the PPE usage. We had to really sit down and think, okay, we bring the patient out of the hospital and we're transitioning them into another hospital, clean PPE, dirty PPE, like what can we sacrifice, what can we not? And we had to look at places that, hey, you know what, we don't really want anybody walking down the halls with dirty PPE. They would come up with clean PPE. We would transfer the patient. We did a lot to preserve PPE. So yeah, there was a lot of challenges, but somehow we worked through it.
Mm-hmm. I was really grateful for our customer service managers, because I know you guys were out there pounding the pavement. And I would get calls or emails. They're like, hey, I found 5 masks. Send them. Send them. So excited. I mean, I was like, I couldn't believe we were in this situation again, but I was just so excited to get that. And I was really proud of our team. Well, we all learned a lot of lessons, and this was a lesson that I certainly learned about collecting data early, and I call it collect data early. I don't have a clever name for it, other than if you think you're going to need something now or in the near future, just start collecting. If something enters your mind, like, oh, I wonder if I'm going to need to track that or report it. Create a field in a database and get the data. Don't wait for a pattern. Don't analyze things, just start collecting it. Something else I thought was really interesting, and I had been reading about this. It's called continuation bias, because you guys all fly too. I think this will make sense to you in a couple of different ways. So what is that? And you guys have probably heard of James Reason, right? James Reason is this PhD, the Swiss cheese model guy, but he talks about continuation bias, and it's the unconscious cognitive bias to continue with the original plan in spite of changing conditions. And it's often too taxing mentally for people to change their strategies, and specifically when they're under significant stress, like a pandemic. So be aware of and fight the urge to maintain continuation bias. We really needed a system for reporting and tracking PUIs and COVID-19 positive patient transports. And initially, we used our quality management reporting system. Really, with a few small changes to the database and process, we were up and running. Additional data fields were identified and added to the database. If we transported a PUI, meaning we were waiting for COVID-19 patient test results or waiting for initial testing, the crew submitted a quality management report and selected the appropriate data fields. The quality management department then assigned this report to our team of awesome investigators. Investigation included follow-up with receiving and sending hospitals to determine the COVID-19 status of the patient. The results of the tests were then sent to clinical leadership and the crew involved in the patient transport. We were also able to track and report the amount of PPE used on each transport and any concerns with PPE or potential exposures. All the data from the QM reporting system was downloaded twice daily into our COVID-19 dashboard for ongoing analysis and reporting. Veronica, I'm going to ask you another question here, and then I know Lolita's going to be jumping in because we're going to get to that dashboard real quick. But the crews were so great about reporting. I mean, how did we get their buy-in? Because they're just wonderful.
Right. It was just one more thing to do for them. I think that the true buy-in was that we were trying to protect the crews and the patients that we were flying. I mean, the bottom line is we were trying to figure this out. And I think that everybody was on board. Everybody wanted more information. They wanted to be able to protect themselves. They wanted to make sure that their patients were protected. And that is kind of the key, that they were getting answers. So the process was the flight crew would fill out the QM and essentially said, hey, this patient, we don't know, became in particular play when the patient was like a trauma patient or a scene patient. We didn't know necessarily. And then customer service, that was one of our roles, is that we would actually do the follow-up and we would make the phone calls either to public health or we'd call the hospital. We would work with different hospitals in different ways to get this information and get it back to the crew. And I think that in some cases, this helped crews to know when to isolate or, hey, I've been exposed, or they were able to use it to protect themselves during this time of chaos and all kinds of information, and nobody really knew what to believe. And everybody just understood this is a problem and I don't want to get anybody else sick and I want to do the right thing for the patient. So I think that is where we really got the buy-in, which has been fantastic.
That was really great. I don't know if you've all probably seen this, but this is a picture of our COVID-19 dashboard. And this was designed back in March of 2020. So just the functions of the dashboard was to track COVID-19 patient transports, sending, receiving facilities, each of these transport bases, crew, vehicle type, PPE, inventory, burn rates. And then of course we use this dashboard for our predictive modeling. As I mentioned before, we needed to pivot really quickly from a reactive model to a planning and predictive model. We transported our first COVID-19 positive patient on March 6, 2020. And you can see that bottom graph down there. Our transports really kind of correlated with surges throughout the states and the country. Lolita, I'd like for you to kind of walk us through this dashboard and give us an interesting story about the design of it, because Lolita was really the brains behind this whole dashboard, and she got it up and running in 2 weeks, less than 2 weeks.
It was a very strange and intense time, right? This was at the beginning, no one knew anything. And right before everything shut down, my department grew exponentially. We doubled to 2. And so for the first time, there was more than one of me. And so we were learning how to work together and trying to build this at the same time and wondering if we needed to do more or something different to protect our own kids and our families. So it was really intense, but it was also really great to have something to focus on. Sitting behind my computer monitors, dragging fields around, trying to build something just took the focus off of this, everything we don't know. And here's what we do know. And to be able to provide a place for people to see this is what we do know was really reassuring. The first thing we needed to know is who are we transporting and how much COVID are we really seeing? And at the beginning, I remember there was a lot of follow-up to be done. People really didn't know. Testing was so scarce. It was uncomfortable. It was alarming because we really didn't know. And this, the map at first was very, very different. You could see the clusters at the beginning, and knowing where, being able to see quickly visually where the patients were was really helpful because you knew that's where everything was the most intense at the time. And it was terrible and fascinating to see our volume increase. However, maybe 2 weeks after cases were increasing, the patterns really showed up in the data.
I was looking at that Johns Hopkins dashboard early on, and I went to Lolita, I went to our BI department. I said, I need something like the Johns Hopkins dashboard, only better. And I wasn't joking. And something else that we really needed to track, there was, yes, the cases and who was transporting all that. But it was really our PPE, because this really was a big concern of ours, and you need to know where it was. And Lolita, I've got a couple of slides here if you want to kind of just walk us through what's on this slide and anything interesting here you want to point out.
So those forms, those fields that we were talking about before, that information started to come in, and we quickly built a system to compile it. And this involved a lot of manual work on our side. I know it was a lot more work for everybody out in the field, but typically this is something that I wouldn't do. Something that requires really intensive manual work. I would say this isn't sustainable. We have to find a different way to do it. But that wasn't an option. There was no other way. There was no time to develop a different system. So we spent time downloading and formatting data before it could be uploaded to this dashboard. And we took the PAR level that was entered, and we took the existing numbers and just tried to show like who was using what and where. And we set up these averages and this estimated growth to kind of give people a sense of how bad is it, or are we okay? And one of the critical things about this whole process was definitions. At the beginning we had inconsistent counting. Like the biggest example was gloves. Some people were counting pairs, some people were counting boxes. It was a huge difference. You can say you have 20 and I'm like, oh no, what you mean boxes? So that idea of definitions was really challenging, because we didn't have time to have a meeting to talk about what we meant. It was just like, no, go tell people it's a box, So it was a very different way of operating. This particular dashboard uses data from several different sources. We had to know how much we had, but we also had to know how much we were using. So we had the inventory system, and we had what was at the time the QM reports to know where we were using and how much. And we could say, well, recently we picked the past 7 days, we have used this much per day, per transport. And at that rate, if that average holds, we'll run out in X days.
And as our supplies were getting scarce, it was even more important to get that accurate accounting of the PPE and decontamination availability and the rate we were using our supplies. This data had to be reliable, and it was a really important part of our predictive modeling. And it enabled us to even move supplies ahead of demand. At this pandemic, data was driving all of our decisions, and it had to be accurate. It had to be timely and had to be accurate. Thank you, Lolita. Thank you, Lolita. So this is looking at a little bit of tracking and predicting. So we're looking at a 4-state reporting of COVID-19 cases and deaths here. And you can see the state map on the right. And this, of course, is our primary service area. And we closely followed this data because it really gave us like a crystal ball look into the future. As cases increased in various counties and states, we knew that transports could happen immediately or mostly to follow. Our initial and largest response for COVID-19 transports was in Southwest Washington and Southeastern Oregon locations. These transports then moved predictably, actually, to Idaho and then to Montana. Knowing what was coming, assisted our materials manager to move PPE and decontamination supplies to the next hotspot. So yes, once again, shifting supplies ahead of demand. As the pandemic progressed, our referral patterns varied greatly. As COVID-19 cases increased, so did demand for air medical transport. And unfortunately, as the pandemic progresses, especially with that Delta variant, we were called upon to transport patients outside of our normal referral patterns. Whereas in the beginning of the pandemic, our biggest challenge was obtaining PPE. Later on, and now our biggest challenge is carrying enough oxygen due to the fact that these are critically ill patients. These COVID-19 patients use a tremendous amount of oxygen and are many times now being transported great distances. So this was a logistical challenge for our pilots, our medical staff, our communication specialists, operational control center. So this pandemic has been an ongoing effort to be creative and develop innovative solutions. And working collaboratively, our staff has responded with innovative system improvements and continue to provide transportation and excellent critical care, even during all of these challenging times. we're looking at a screenshot of Idaho. As you remember, Idaho implemented their crisis care policy during the fourth wave of the pandemic, late summer, early fall of 2021. And Veronica, I know our referral patterns changed, and we had to go from rotor wing to fixed wing, and we'd have enough oxygen, we'd have to land. It just seemed like it just went crazy, but I know we responded. Do you have any, would you like to chime in on that, on those challenges that we had?
Absolutely. Yeah. So that's exactly what was happening is patients were going greater distances, and we again had to pivot. It wasn't, we kind of got the PPE kind of figured out. I think that was moving, we were flexible. We got that side. How then the game changed again, and hospitals were full, and we were going to have to take these patients that were very, very sick with high consumption of oxygen that needed to go, maybe northern Idaho to Utah, or from Montana to Seattle. That's a long ways to go with patients. And that was becoming the norm. Our normal transport referral patterns weren't occurring. So we had to then figure it out. What could we do? What could we put in place? Do we do wing to, one transfer on this mode and then transfer to another mode, just so that we kept having enough oxygen? Would we have to transfer over, taking on additional oxygen where we could? We really had to get the crews involved to speak up as well, is, hey, what do I need to do to make this transport safe and get it done for the patient? So there was a lot of challenges. We did a great job, I think, in pivoting. And again, it's about the flexibility and everybody being on board and everybody understanding what was needed. And truly that helped everybody pay attention. So if one person kind of spoke up and said, this isn't going to work and this is why, it wasn't the norm, like, oh, okay, no, okay, tell me what you need. And we were really good at just pivoting and making sure that people had what they needed.
Yeah, this pivoting is really a key term here now. And it was so important. I think that's something that we can be really proud of and share. Reporting and tracking of COVID-19 related reports eventually did overwhelm our QM system. Reporting COVID-19 related events in our QM system was a really, really great start and helped us with our initial response. However, by just December of 2020, we could no longer keep up with tracking and reporting of all things COVID-19. So based upon the challenges we identified, we changed our system. So staff are now only required to submit QM reports for PUIs, or if there was an exposure problem or a problem with PPE. So all COVID-19 positive patients the tracking is still occurring. However, we're using a different system and 2 other databases. Clinical and business intelligence continue to track and report COVID-19 cases, and you can tell our dashboards up to date, and to push this data to the COVID-19 dashboard. So in 2020, about 40% of our QM reports were COVID-19 related. And then it dropped to just from January to August 2021, they were only 10%. But you can see in this slide, it was pretty crazy. So something that I thought I should probably start tracking also was the employee suggestion reports. So part of the QM system is managing our employee suggestion reports. All employee suggestions submitted between March 2020 and August 2021, about 47% or 62 were COVID-19 related. And the majority of employee suggestions were entered within the first 6 months of the pandemic. But what's interesting is among the 62 employee suggestion reports submitted, 45% of these suggestions were ultimately implemented, and they were great suggestions. The lesson here is that our staff have really great ideas, of course, and because many of their ideas were implemented, they felt listened to, and they were part of the solution. I really enjoyed reading those employee suggestions, and then even more importantly, I enjoyed it when they were implemented. And then people will continue to submit if they feel part of this solution and that we are improving. So I like this. This is a little funny thing here, but it says, I come from 100 years in the future that warn you that nothing really changes in the next 100 years. And I call this really just our cycle of crisis and complacency. And basically, this could be us if we sent somebody back to 1918 and the 1918 pandemic. if you read about that pandemic, it's interesting because sadly, many of the challenges that the US faced during that pandemic, 1918, we still face today. I guess the questions are really, how do we fight complacency and learn the lessons? And I guess this next question is, really, can we improve? This really is our wake-up call. So there, of course, will be more pandemics, and the frequency is increasing. So let's be prepared, and let's have a plan. Hope is not our plan. Let's remember the past and apply the lessons learned. So here is my recommendation. Even in the midst of a pandemic or health crisis, document what you're doing, why you did it, how you did it. I documented almost everything our initial response team did step by step, the why, the what, the how. People thought it was a little bit crazy when I showed them this document. But as it turned out, it was a handy reference tool, both for this presentation and for an after action review, a COVID-19 after action review. So real quick, how many of you have been involved in an after action review, either here at LifeLight or at another organization?
It looks like everybody from our audience has.
That's cool.
Good. It's really interesting. There was an independent panel for pandemic preparedness and response. I don't know if you've heard about this panel, but they gathered last May to review the world's handling of this crisis. And they found weak links at every point of the chain of preparedness and response. I'm quoting, preparation was inconsistent and underfunded. The panel said in the report, the alert system was too slow and too meek. The World Health Organization was underpowered. The response has exacerbated inequalities. I think we can all agree on that. Global political leadership was absent. Too many countries took a wait and see approach rather than enacting an aggressive containment strategy that could have forestalled the global pandemic. So let's remember our lessons. So don't wait for the smoke to clear. There are no points for inaction, and we need to act, and we need to act quickly. On August 25th in 2021, LifeLight Network actually did hold an after action review, even though we were still in the pandemic. 15 departments were represented and reported on what went well and what didn't go so well, opportunities for improvement, lessons learned, and system improvements that were implemented. And we identified 8 common themes of what went well and 7 common themes of things that didn't go well or just went wrong. These notes were memorialized and distributed in an after action review report. So what didn't go well or opportunities for improvement, many had to do with communication, as you can imagine, and how fast things were changing and concerns about PPE. And opportunities for improvement included being proactive versus reactive, increasing our supply chain, having more tabletop drills in preparation for these types of events, and pivoting more quickly to an incident command system. Many people felt we should have done that a lot quicker. So even though we shifted roles and assigned assignments to the not so what you would call usual suspects, we still layered on too much on certain highly experienced staff members. For instance, a few employees got an enormous workload early in the pandemic. We eventually became more efficient and distributed these workloads. This was just probably a weakness in situational awareness and monitoring, or we were just also exhausted or tired. We should have pivoted sooner and look more closely for staff qualified to help us with these additional workloads. This would have helped make sure that no one person was overloaded. So a couple themes of what went well. Well, there were a lot, but I'll just name a few. So our staff were resilient, they're flexible, we were adaptive, we were committed to help, and we were collaborative. We had no interruptions in service, and we used the most up-to-date science to care for our critically ill COVID-19 patients. We were able to collect data early, and we used data to drive decisions. All right, back to our question. So if you took $1 million, you get $1 million. If you took a penny a day, At the end of 30 days, you would have over $5 million. $5 million. I mean, it's funny because on day 10, day 7, you've got 64 cents. On day 14, you've got about $80. Day 22, 10,000. And then all of a sudden you've got 5 million. What if you had picked a month with 31 days, you'd have over $10 million. As it turns out that when you ask the question to people, 90% of people will pick the $1 million. Okay, so that's a challenge for all of us. So let me share a quote from the public health company real quick. It appears that disease was nowhere and suddenly it was everywhere. There was exponential growth of the virus all along. It was just invisible to you until it wasn't. We often underestimate exponential growth. So we transported our first patient, our first COVID-19 patient on March 6, 2020. But it wasn't just one case. There were actually hundreds and thousands of cases in our community. We were already behind the curve. We just didn't know it. In everyday life, we witness exponential growth, right? The spread of a fire, interest on a credit card, yet we underestimate the consequences of exponential growth. So even though I had a bad feeling when I saw that 1,600 bed hospital built in China, I was worried about the problem, maybe worse than known. I probably underestimated the consequences of this growth, consequences for our safety and for our company and for healthcare in general. In conclusion, we do seem to live in a world of crisis and complacency. So during a pandemic, especially during the early stages, I've noticed that we are in the moment and we're serious and concerned and engaged and adaptive. But then as we proceed with this crisis, we can quickly become complacent. Why? Well, because we are really quick to return to normal, to delay repair, to claim we don't really have the emotional resources, societal bandwidth, or funding to make the necessary changes and plan for our future. If this is truly the cycle in which we live, crisis and complacency, we will not be better prepared for the next pandemic. So knowing this, what is your plan? Think about how you will respond, how prepared you need to be. How will you protect yourself, your friends, your family, your community, healthcare institutions to safely navigate the next pandemic? So the ability to pivot and react quickly will save lives. So let's not forget the valuable lessons we learned from COVID-19. Remember, identify what's important and drop everything that's not. Ask yourself, what is your escape fire? Thank you for joining us today. We'd like to give a special thanks for those of you working in healthcare. You are amazing. If you'd like to contact us, please send an email to info@lifelight.org or call 503-678-4364. Once again, thank you for joining us today.